Hello everyone, my name is Smita Agrawal. I'm Senior Director of Product Management at Concerto Health AI, working with the AI and data science team. Today, I'll tell you about a project that the team did on imputing lung cancer subtype from electronic health records data. This work was selected for a poster presentation at ISPOR 2020. So let's get started. There are two major types of lung cancers: small cell lung cancer or SCLC and non-small cell lung cancer or NSCLC. NSCLC is the more predominant subtype with an incidence rate of about 85%. And treatment pathways as well as outcomes for patients with NSCLC and SCLC can vary significantly. Any retrospective analysis of real-world patient data for health economics and outcomes research requires the ability to distinguish between these two lung cancer subtypes. However, structured data from electronic health records captures diagnosis using mostly ICD codes, which does not have a provision to capture these two subtypes separately, and there's a single code for all lung cancers. So there have been previous efforts to develop rule-based approaches using therapy and test information to identify NSCLC as well as SCLC patients from structured claims databases. The challenge, however, of using rule-based algorithms is that these include treatments and tests that are performed predominantly on one subtype, but they're not mutually exclusive. And to our knowledge, the best performing algorithm using such approaches has an AUC of 0.88. So we asked ourselves, could we develop a machine learning based algorithm to identify NSCLC patients from a cohort of heterogeneous lung cancer patients from de-identified retrospective EHR databases? So how did we go about doing this? We used the machine learning technique called XGBoost, and our model included features such as lab tests, staging information, surgery information, medications, and patient metadata. All in all, our model had 325 features. And the model allowed us to integrate various features and also account for interactions between these features, which we believe makes our model predictions more accurate. We used over 56,000 lung cancer patients selected from the ASCO CancerLink dataset. Of these, about 85% were labeled to be NSCLC. How was this labeling done? This was predominantly done by expert nurse curators going into the unstructured notes and identifying the subtype. A small percentage was also identified using histology information when it was present in the structured data. We extracted the features from the structured data, such as diagnostic codes, lab values, medications, and cancer stages, and then this data was harmonized using medical taxonomy. Finally, we applied the XGBoost classifier with a depth of 8, and it uses 10,000 estimators. We divided our data set into a 60-20-20 split of train, test, and validate. And then finally, we validated our model using an internal holdout control. So how did our model fare? Our ML model actually performs significantly better than the best performing rule-based model that's out there. As I mentioned, the best performing model had an AUC of 0.88, whereas with our ML model, we can achieve an AUC of 0.93. The area under the precision recall curve is even better at 0.98. And for predicting NSCLC subtype, our model has a precision of 0.93 with a recall of 0.99. The overall accuracy of the model was 93%, with the PPV of 0.93 and an NPV of 0.9. Furthermore, we looked at the features that were driving these predictions. On the right is a SHAP plot that provides the top 50 features that the model is using to drive predictions. This is a little hard to read, so I've actually summarized the key results in the table on the left. So as you can see, features such as genetic tests, lung surgery, usage of targeted and immunotherapy drugs, as well as usage of chemotherapy drugs such as pemetrexed, carboplatin, cisplatin, docetaxel, paclitaxel, vinorelbine, and gemcitabine all drive prediction towards the NSCLC subtype. Whereas usage of chemotherapy drugs such as etoposide, topotecan, and irinotecan drive prediction towards the SCLC subtype. As you can see, most of the features of significance are as expected from a clinical perspective. but we believe that it is the interaction effects of these features that allow for a more accurate prediction. Furthermore, features such as age of diagnosis, gender, and race also have a modifying effect in the model. So in conclusion, we see that the power of machine learning allows modeling of hundreds of features and their interactions, and this in turn, we believe, provides significant improvement over rule-based algorithms. We believe that this model can be used to significantly reduce time involved in screening patients for inclusion in cohorts for various health economics outcomes research projects. Thank you so much for your attention and your interest in our research. Goodbye.